Good morning, good afternoon, good evening, wherever you are. Welcome to the fourth webinar in the Challenges and Novelties of Pediatric Pathology, sponsored by the Royal College of Pathologists, together with the support of the International Association of Pediatric Pathology, or International Pediatric Pathology Association, IPA, and all its corresponding societies. Today we have two outstanding speakers. We need to thank Dr. Abbas Agaimi, the editor-in-chief of the Fouchardiere journal, the oldest journal in pathology, and his associate editor, Dr. Leticia Quintanilla, for helping us to put together a very nice special issue that was published at the beginning of this year in Fouchardiere, dealing with many areas of pediatric pathology. I'm going to pass the word to Dr. Isabel Colmenero, my associate guest editor in the special issue and host of this webinar too, who will introduce the first speaker. Isabel.
Thank you very much, Miguel. Good morning, evening, afternoon to everyone. As Miguel said, I'm Isabel Colmenero. I'm a pediatric pathologist and dermatopathologist at Hospital Niño Jesús in Madrid. Thank you, everybody, for joining us today in this webinar, which is the fourth of this series. And the seminar today will run for approximately 1 hour, and it will include two short presentations, about 20 minutes each. After the presentations at the end, we will have a short session of questions and answer. If you have a question for the speakers, please use the Q&A function at the bottom of the screen. And please note that the webinar will be recorded, and the recording will be available at the website of the Royal College of Pathologists. And attendees can self-credit 1 CPD credit point for attending this webinar today. So it's time to start and introduce our speakers. The first speaker today is Dr. Arnaud de la Fouchardiere. Arnaud is a clinical dermatologist and histopathologist and an expert in molecular genetics. He works in the cancer center in Lyon, and in his practice he is focused on the diagnosis of melanocytic tumors, particularly Spitz tumors in pediatric patients, but also in adults. And he received many consultation cases from all over the country, France, and also the different places all over the world. And he's a specialist in molecular genetics, and he has contributed to the molecular classification of Spitz tumors. So we are really proud to have Arnaud here as a speaker today. Arnaud?
Hello, thank you for the introduction. Hello, everyone. So I'm going to talk about the Spitz tumors today. So I'm going to talk about the complexity of this group, and what I'm working as a research is to find the links between clinical data, histological, and genetic features. And I'll talk about the importance to distinguish Spitz and Spitzoid as a terminology point, and also talk about the global risk of overtreatment of Spitz tumor, especially in children. So I think that now we think that the problem is, ever since Sophie, like everyone has their own vision of the Spitz group, because it's a very complex group. So Spitz tumors go from nevus, intermediate tumors called melanocytoma, or a typical Spitz tumor, and sometimes, very rarely, melanomas. And there is a lesional continuum, and these are mainly have a common cytological criteria, and there's lots of different genetics. I'll go through all this. Globally, this is really a low grade of malignancy, although it can be very worrisome under the microscope, and they have a very good outcome overall. So there are 3 groups of lesions in which you can go from a nevus to a melanoma, and this is the tumor of blue nevus, the common nevus was the most frequent, and last is the Spitz nevus, which I'll be talking about today. So in this progression, we know that there are some genetic anomalies that are very frequent in the progression from Spitz-Neves to Spitz intermediate tumor, which is mainly anomalies in CDKN2A, such as deletions, and this can be observed with loss of P16 expression in a clonal part of the tumor. For melanoma, it's quite difficult, and one recent factor is the presence of H-shot mutation has been found to be associated with some fatal cases. So globally, when we do molecular pathology, a lot of melanomas have a bad prognosis when they are already in the lymph node, but that's not the case for the Spitz group. So start with Spitz-Neves. These are mainly observed in teenagers or young adults rather than in children. They grow very quickly in under 6 months' time. They're usually elevated tumors, and there's some frequent areas such as lower limbs, especially the knee, and the cheek and ear areas of the face. So they have been described in the WHO as having a special morphology, which associates hyperplasia of the epidermis that looks like almost a carcinoma, and this is like a good example. And we have this clefting around junctional nests, and we have here a lot of cells that we're going to go through. So basically, there are two main cytology in Spitz-Neves: spindle cytology and epithelioid cytology. But most of the time, we have a mix of both of them, and spindle being the most predominant in terms of frequency. So there's lots of subtypes of Spitz-Nevi. I'd go through a lot of them. And there are some clinical subtypes, which is polypoid lesions here on the cheek of a child. These are often thought to be vascular tumors because they're highly vascularized and not so much pigmented. Some other clinical aspect is acuminated Spitz-Neves. This arises in a background of nevus spillus, and they look like different tumors that are close to each other on the skin with intervals of normal skin. Moving to architectural subtypes, Paedatoid Spitz-Neves is kind of worrisome because there is like ascent of cells that can mimic SSM, and often this is going to be the main differential diagnosis. You're going to have to try to select which cases are Spitz and which cases of SSM. And of course, the global outcome is really different in both groups, and that you're going to spend a lot of time to rule out SSM. And in this case, for example, ROS1 immuno shows that there's probably a ROS1 fusion in this case, and this is very typical of the Spitz group. I'll go back to genetics afterwards. Now, moving to other architectural subtypes, this is one of the most frequent. Plexiform Spitz-Neves has this wedge-shaped silhouette, and the epidermis looks like a parachute from the low power. And here's another example of this very nice wedge shape. And when you look at high power, you have strands of spindle cells in the fibrous background, some blood vessels, not too much inflammation, and here have some bland nuclei. Here's what they look like clinically, like they have more hyperpigmented tumors, and usually will have a very strong P16 expression. So P16 is like not lost and very strong in the benign tumors, and then can be lost in the progression model. So this P16 is really going to outline the plexiform architecture. It means it mimics nerves. Regarding genetics for this plexiform, we have maybe 2/3 have ALK fusions and 1/3 have ROS1 fusions. Another very strange architectural subtype is pseudoschwannomatous Spitz-Neves. This has a special intradermal component, but usually you have a very abrupt transition from normal melanocytes on the top to this spindled architecture. Another architectural subtype is plague-type Spitz-Neves. Most of Spitz-Nevi are not so big, but this one will be over 1 centimeter, and they will be like having this pattern of small nests that's going to be identical from one side to the other with not too many aditya. And you see, it doesn't go very far deeply into the dermis. And we can see the dilated blood vessels that are frequent in this setting. And now moving to the stromal-related subtypes, we have the desmoplastic Spitz nevus, which has a fibrous background and not so much cellularity. They also have frequently a wedge-shaped silhouette, and they're not very cellular. You often see more the fibrous background and have the distorted cells that can be more isolated than fasciculated. In this setting, what is interesting with immuno is you're going to have a stronger expression of P16 compared to myelin A, which can be top-heavy. And this is quite heavy. I'm trying to give you some clues to use immuno as already a molecular approach to classifying these tumors. And I think another stromal-related subtype is angiomatous Spitz nevus. This has predominance of blood vessels with dilated lumens, and you're going to be maybe more focused on the lumens and less than on the isolated melanocytes that are found throughout the tumor. Often you can have a combination of the different subtypes, just as you can have angiomatous and plexiform or other subtypes together. Usually also we will find ALK and ROS1 fusions in this setting. The last stromal-related subtype is the myxoid Spitz nevus. This can be sometimes really strange because the Spitz is the myxoid features will be predominant, and you have a few floating cells. And this is what we describe as the MyStar variant, and often they will have ALK rearrangement. And then when the tumor is really early removed, it's going to be very not specific, what we call not otherwise specified NOS Spitz nevus. This often will be ROS1 fused. So moving to the cytological subtypes, we have really what is the pigmented spindle cell, what is called also reed nevus. It has a fast growth. It's very frequent on the knee of children. Appears as a hyperpigmented papule, and when you look at with a dermatoscope, it has this typical starburst pattern that I show you on the right. When we look at the morphology, it's going to be mainly junctional with all these vertical nests. They can be confluent nests, and they have this vertical orientation, and always epidermal hyperplasia that starts and ends with the tumor. So here's some example of the vertical nests. They have small, spindled, hyperpigmented melanocytes, and often very few dermal nests. And there can be a transition from reed to Spitz. That means they will lose the starburst pattern and have like areas of depigmentation. That's usually when they are removed. And then when we look at these tumors, some part is like reed and some part is like Spitz. So this is an example. Here it's half and half. On the left part, you have really the vertical nest of spindle cells of the reed nevus, but on the right part, you have the same nest, but they are made of larger cells, which have kind of lost the heavy pigmentation and look like more spindled, large spitzoid tumor cells. Another subtype is pseudogranulomatous. Usually they have MAP3K8 fusions. I'll go after in genetic part about these anomalies. And also we can have pigmented epitheliocytoma, PEM, with a Spitz background. That means they have PRKAR1 alpha inactivation. This is a good example. You have the hyperplasia of the epidermis, and you will have spindled epithelioid melanocytes. So if you go back to the progression scheme, mainly here I've shown you like the field effect as in nevus pilis or Spitz or reed nevus, and then we have progression possibility to middle grade or high grade tumors. So size matters. As the tumor are more aggressive, they will be larger tumors, and usually melanomas are going to be quite large tumors. And often we'll have like the clonal appearance. Something is going to happen. It's going to change inside the tumor. Often a nodule and depigmentation occurs in a pigmented tumor. So there's all the criteria for melanocytoma or the usual criteria for atypia in pathology. And it's just a matter that you will have a number of them present or absent in the low-grade or high-grade tumors, but you don't have always all the same elements of criteria, and you don't always have all of them. And usually we have this clonal evolution that there was a pigmented lesion, and then arrives this clone with as a nodule. Here we see this is this case, and only on the side we see the remnant of the junctional that was only spindled hyperpigmented cells, and the clone is made of the large epithelioid cytology. So usually we have this transition from hyperpigmented small cells to large epithelioid unpigmented cells. Here's another example. This child, one year old, very good looking, star burst, everything is fine, but 1 year afterwards, really growing fast and has to be removed. Everyone is worried. The tumor is very exophytic, high density. There is some mitotic activity, but not too high. And there is density. These are criteria, but we don't have really enough for a melanoma. This has to be studied by genetics. There's some atypia, but it's not crazy. Everything is not so atypical. And under genetic, we have all the anomalies condensed on chromosome 15 with break areas in myo5A and NTRK3, which are the fusion partners for this anomaly. So this is a myo5A NTRK3 fused, a typical Spitz tumor, and there's not enough for melanoma with this genetic data. For the melanoma, there will be highly modified, changing tumors, bleeding, and when you look under the microscope, like you have dense sheets of everything, very atypical cells, and high mitotic activity. Here, there's no other way to call it a melanoma. And this child is perfectly well after 10 years. This was from more than 10 years ago. And here's really some examples of really how bulky these tumors usually are. Very bulky tumors and have spindled, and they still are kind of different, and maybe that can be related to a different genetic background. So let's move now to the molecular anomalies. There's basically 3 groups of anomalies: HRAS mutations, tyrosine kinase fusions, and serine threonine kinase fusions. So for the first group, HRAS mutation, usually they are isolated tumor. They have desmoplastic Spitz morphology. That means they have the wedge shape. They have more nest in the upper part. Here it's more pigmented in the upper part. And then it becomes less pigmented more deeply, but not so many atypia. And here has HRAS mutation that we can study by the RAS antibody when it's Q61R mutant. And usually, as I told you, we have melon A is going to be like top heavy, and P16 is going to be like diffusely positive. That can be a little bit of help just to assure you of this diagnosis. Sometimes, besides the isolated tumors, we have the model of the nevus pilus, which usually is a mosaicism of HRAS. And in this setting, you will have multiple tumors arising only in the area that is pigmented. But sometimes the pigmentation is not visible because here, for example, there was very important xerosis. So it can appear as also in somewhat normal skin, but we still have a mosaic underneath. So that was the HRAS. This is now the second group is receptor tyrosine kinase fusions. So these are the anomalies, but the main ones are ALK, ROS1, and NTRK1 and 3. So usually these are isolated, and I'm working to try to find trends between the morphology and the genomic anomaly. And maybe there are different prognostic subgroups for the different fusions. So let's start now with the ALK fused tumor. So you can see there can be very different. Some are very exophytic and verrucous. Some are totally endophytic. But if you go to high power, they most often have this plexiform architecture, that they are similar, whatever the architecture is. And this will be highlighted by often the ALK immuno, showing you this plexiform architecture. Now moving to ROS1. ROS1 is the most frequent anomaly. They will be quite frequent in the plate type, are NOS lesions, and also a few desmoplastic Spitz tumor or plexiform, also Spitz. So here's an example of a plexiform Spitz, wedge-shaped, has not so much junctional component, and has these large cells in the dermis. So usually we have ALK about 2/3, but 1/3 of plexiform is ROS1. So ROS1 by immuno is kind of tricky, but it's like very faintly positive. But usually you have a very neat background. Nothing else is going to be positive besides all the tumoral cells. So if you have doubt, of course, you will do a FISH technique. Now moving to NTRK1 tumors, showing you some papers. So the difference between NTRK1 and the other ones is they usually have more flat base compared to a wedge shape compared to the other tumors. And here's some other silhouette, flat base. And often, besides, they don't have the typical spindled or epithelioid cytology, they can have nevocytoid cytology. That's why they can be confused with a melanoma, especially if it's a large tumor. They can also display rosette. This is quite rare, but it's possible. And another feature is the filigree-like rete-ridges. So I think this is a clinical picture that is quite or very evocative of this anomaly because it has the hyperkeratotic appearance that is the epidermal hyperplasia we have. So these rete-ridges really can go deeply to the bottom of the path. That's what we call this filigree-like architecture. Here, usually the antibody is going to be diffusely positive. And we can see it's going very deeply, that even the epidermis is going beyond where the flat part of the melanocytes are visible. NTRK3 is going to be quite different from NTRK1. So here are the few papers that you will look if you want to go back to the video to look at these papers. So NTRK3 is what we're going to find most commonly in the reed starburst type of Spitz nevus, and the one have confluent nests, the hyperplasia of the epidermis, and that are mainly junctional. And also Myo5A NTRK3 is going to be the main anomaly we find in the pseudocyanomatous subtype. So here I'm showing you again this very abrupt transition from type A and B melanocyte to this spindled unpigmented melanocytes. Again, some other aspects. It can be very small tumors. Here you have the type A and then goes to spindled like very immediately. Also, you can have this clefting that can be a clue for this subtype. So it's like SFT type of clefting that you can see from the low power. And the last group is going to be the serine-threonine kinase fusion. So we had HRAS, a receptor tyrosine kinase, and this is serine-threonine kinase fusions, mainly BRAF fusions and MAP3K8 fusion, whereas MAP3K3 are quite rare. So let's start with the BRAF fusions. So this has a high variety of morphology, and not all of them are looking like Spitz, only like half of them look like Spitz. They are very associated with a fibrotic background. So here the fibrosis is going to be very important to recognize. And there are quite a number of malignant cases that have been found to be lethal cases with this anomaly. So maybe this is maybe a worse prognosis anomaly to have. There's some papers from a lot of teams, and they can. One of the main architecture is going to be the buckshot fibrosis. I forgot the I. So you're going to have basically a fibrotic background like here, and then you can have like kind of nevocytoid cytology in the upper part, and in the middle part you will have like a mix of isolated cells and large cells in the fibrotic background. This kind of resembles BAP1 inactivated tumors. That's how I discovered this, looking for BAP1 tumors. And so this has a very backbone-like inactivated cytomorphology. Here's another example you see from low power, very fibrous but it's more rounded than really wedge-shaped and has these large cells that are isolated. Giant cells can be present like here. And we can have other architecture such as cords and word fibrosis, looking a bit like breast cancer, or some more spindled with large fascicles, high density here. So there's a wide array of morphology. Here's the case from our institute, but initially thought was a melanoma. And it's only when 2 years after it became metastatic that we did the sequencing and found had a BRAF fusion. So these BRAF tumors, they have some metastatic potential, and maybe they should be more cautiously managed or at least followed up. Here's an example of a fatal case published recent. MAP3K8, so the last anomaly I'm going to talk about. These are younger patients, meaning under the age of 10, like 4-year-olds, often on the lower limb, they have a wide ulceration. But this have a very specific clinical setting for this anomaly, and they can have very large epithelioid is mainly the main cytology, and you can find pigmented clones. These have higher rate of local relapse in my experience, rarely lethal, but still not zero. So we can have them as low or like nevi with very superficial lesions having this anomaly. And here we see the progression model. These are the early lesions, have the Spitz read cytomorphology, but usually when they are removed, they are in the intermediate setting with having here the follow-up is gaining some volume, and then it can become a very epithelioid. I'll skip forward because I'm running out of time. Just to show you, so you're looking for these very large cells, that one I showed you in the pseudogranulomatous architecture. Usually progression goes with loss of P16. And we have a lot of melanomas that have this anomaly, especially in children. They have this wide ulceration from the clinical part. This is this case. We see the wide ulceration. And you can see, here's the ulcer. And HME45 can highlight some hyperpigmented areas that you will have the melanin pigment if you look at just this area. Just these are large tumor. Again, here I have the epithelioid cytology, pigmented clones, and this pseudogranulomatous, very strange cytomorphology. So what is the diagnostic input of finding a kinase fusion? So if you have an ambiguous metastatic tumor and you're not sure it's Spitz, so that's something you call Spitzoid, then if you identify the kinase fusion by any sequencing or IHC, then you can call it a Spitz. It's going to be regrouped with the Spitz spectrum, and globally this will be associated with a global better outcome, and maybe you don't need to do such a wide excision for these children. And also there's some possibility to treat them with specific drugs if ever things go bad. So what we look in this large series is that we're able to find drivers in most of the cases, and there was no specificity for ROS1 or NTRK1. Plexiform was really linked to ALK, pseudoschwannomatous to NTRK3, but always MYO5A, NTRK3. Atypia P16 loss linked to MAP3K8 fusions, and the fibrous background to the BRAF fusion. So these are the main trends in terms of the correlations between morphology and genetics. And if we look in children, which are the cases who go to a high grade or malignant status, these are mainly ALK fused and MAP3K8 fused for the most part. So the take-home messages for this Spitz tumor, this is going to be a step-by-step diagnosis. You're going to try to identify these anomalies that will classify the tumors as part of the Spitz group, and maybe we are moving towards a more specific molecular classification. And for us, it's important now to have follow-up study to know how the MAP3K8 fare compared to the ROS1, compared to the ALK, and so on. And this is my final slide. I thank you for your attention and being here with me today was really a blast. Thank you.
Wow, thank you very much, Arnaud, for that fantastic lecture. It's a very complex field, and you gave us a very good landscape. We are now going to move on. The questions and answers session, excuse me, will be at the end of the next presentation. And it's my pleasure to introduce a dear and distinguished colleague, my friend Jessica Davis. Dr. Jessica L. Davis is the Centennial Professor of Pathology and Laboratory Medicine, and she serves as the Vice Chair of Anatomic Pathology at Indiana University School of Medicine, a very prestigious institution. Jessica's practice is on bone and soft tissue and in pediatric pathology. She received her medical degree from Oregon Health and Science University and completed training in anatomic and clinical pathology at UCSF, University of California, in San Francisco. When she was there, she completed a surgical pathology fellowship emphasizing in bone and soft tissue, and then moved to a very good place, the Seattle Children's Hospital. She joined the Pediatric Pathology Fellowship there with a very excellent group of colleagues. And then she also serves as the Children's Oncology Group. As the central at the Children's Oncology Group, she serves as the central pathology reviewer for non-rhabdomyosarcoma, soft tissue sarcomas, and bone sarcomas, and is on the steering committee of bone tumors. She's the pediatric representative to the College of American Pathologists Cancer Committee, and is active in the USCAP Society, and the Society of Pediatric Pathology. She's written close to 100 publications, reviews, articles, and book chapters, the later of which include invited contributions to the 5th editions of the WHO classification of bone and soft tissues, pediatric and skin tumors. And she has been an invited lecturer at numerous regional, national, and international meetings and conferences. It's my real pleasure to have you here. Jessica, please go ahead.
Thanks, Miguel. It's really my pleasure to be here this morning, this afternoon, this evening, wherever you are. We're going to shift gears from melanocytic and spitzoid neoplasms. That was a whirlwind and an amazing lecture to focus on round cell sarcomas. So today I'm going to kind of go through and hopefully shed some light on what is the current classification of round cell sarcomas, at least what was established in 2020, and also kind of pivot a little bit to talk about where we might be going with the new WHO, which will be released this next summer in 2026. So this is the current classification of round cell sarcomas as it stands now, and kind of talk about what we can do morphologically, and then how we can use some of our ancillary tests, our immunohistochemistry and molecular, to help us classify these tumors, and then how I think about my personal approach to diagnosis when we get one of these, usually these days on needle core biopsy. So first, let's start with our prototype of Ewing sarcoma. So I think most of you on this call probably are very familiar with Ewing sarcoma, but for the sake of completeness, let's talk about Ewing. So typically Ewing's occurs in the long bones or in the pelvis, particularly in the pediatric population, but a subset of Ewing's are soft tissue tumors. These typically occur in the first or second decade of life. And like I said, in the pediatric population, most of these are in bone. However, in the adult population, a significant subset of Ewing's are in the soft tissue. The soft tissue sites include the chest wall, the paravertebral soft tissues, sometimes in the retroperitoneum or in the extremities. Sometimes we can even see these viscerally located, so really a spectrum of locations. What does Ewing's look like? Well, I think all of us wish that when we got a biopsy of Ewing's, it looked like this. This is from a resection, not from a biopsy, but this is the prototype, right? So we see sheets of monotonous round cells with very clearly defined cell membranes, nice, clear, pale eosinophilic cytoplasm from our glycogen, and really fine chromatin and very ovoid to round nuclei. So this is what we always hope to get. We can look at it and we're like, wow, that looks like a Ewing sarcoma. I think most of us could recognize this and diagnose it. But in reality, what do we get? At least for me, we have shifted our practice more and more to needle core biopsy, and this is often what I get. And our interventional radiologists will say, we got, 7 really nice needle cores. And I will say, well, most of those needle cores were really crushed or necrotic. And I have this one speck of tumor that, I think looks like Ewing sarcoma, and our diagnostic abilities are really limited. And I have to squint and say, yep, I think that looks like Ewing's. And so this was a case I really did have. And they had told me, we got an amazing sample for you. And I said, it's an amazingly necrotic sample, but I still think it looks like Ewing's. And so this is what we're facing more and more. But let's go back to, yes, I'm giving a lecture, so I'm going to show you my most beautiful photogenic example. And so going back to Ewing's, it should have diffuse membranous staining for CD99, as I'm showing you here. And then if your lab has it, a nice nuclear expression for NKX2.2. And I really, for a diagnosis of Ewing's, I like to see both of these. Neither of them are wholly specific, but in combination with the morphology, we can feel pretty good in the right clinical scenario of Ewing's sarcoma. But what about molecular? So as Arnaud mentioned as well, we're moving more and more to using molecular as well as morphology and our immunohistochemistry and our clinical scenarios to put together a diagnosis. So in the last iteration of the WHO, Ewing's now has a molecular definition of having a FET-ETS gene family member fusion. The most common, as everybody knows in this audience, is going to be Ewing's to Fly1, which is seen in about 85% of Ewing's. And second most common is Ewing's to ERG, seen in about 10% of cases. However, there is a smattering of other gene fusions that we can see. There are, unfortunately, some pitfalls in the diagnosis of Ewing's that I'm going to talk about briefly. We have adamantinoma-like Ewing's, which may or may not truly be the same entity. We have Ewing's with complex epithelial differentiation. Luckily for us in the pediatric space, both of these are uncommon in pediatrics, although we may see them. They're much more common in the adult space. We can have Ewing's with extensive neuronal differentiation, which is what I'm showing you here. This is a case I had while I was at UCSF, which the original biopsy in this patient was more conventional looking Ewing's with sheets of round cells and did indeed have a Ewing's Fly1 gene fusion. However, on recurrence, we can see here that this recurrence had abundant neuropil as well as ganglion-like cells. But this indeed was not a neuroblastoma, but rather a Ewing's with extensive neuronal differentiation. Other things that we need to be mindful of is that Ewing's can indeed express keratins, particularly in adamantinoma-like and Ewing's with complex epithelial differentiation. They can express neuroendocrine markers, as well as S100 and desmin. So what about adamantinoma-like Ewing's? So currently this is classified as a subtype of Ewing sarcoma. This may change, and we'll talk about why. These usually occur in the head and neck region, although they can occur in other areas. As I mentioned before, these typically occur in adults. However, they can occur in adolescents. And morphologically, as shown here, they usually are nested or have a trabecular architecture pattern. And by immunohistochemistry, these show squamous differentiation with expression of both high molecular weight keratins, such as CK56, as well as markers that we really think of as true squamous differentiation, including P63 as well as P40. These still will have expression of CD99 and NKX2.2, just like more conventional Ewing's. These may also show neuroendocrine differentiation. Just recently in my institution, we had a case of adamantinoma-like Ewing's that was originally at an outside institution called neuroendocrine carcinoma. And then on re-review, we recognized that this was actually adamantinoma-like Ewing's and indeed had a Ewing's Fly1 gene fusion. The outcome data is relatively limited to date, but these perhaps have a better outcome than classic Ewing's. So why do I say maybe that these might be a separate entity? So there's a couple of papers published to date that looking at methylation profiling, that these cluster separate from conventional Ewing's. So here we have Ewing sarcoma with classic features. And then we have adamantinoma-like Ewing's, and this is just kind of a blown up bubble of those same cases that form a very tight and discrete cluster away from classic Ewings without co-expression of high molecular weight keratins and P40, and away from other head and neck squamous cell carcinomas. So again, these are still right now classified as a subtype of Ewings, but this may change over time. So what are some other pitfalls when we think about Ewing sarcoma? So I really want to focus on a couple. One is a relatively recently described entity of superficial Fettet's neurocystic tumors, and then of neuroendocrine tumors, particularly of the pancreas, may also harbor Ewing's FLI1 gene fusions. These are extremely unlikely in children and have really only been described in adults. And these typically have other genetic alterations. But unfortunately for us and our clinical colleagues, Fettet gene fusions, Ewing's FLI1, is not pathognomonic for Ewing's. So I know many of our clinical colleagues love to do molecular and they say, oh, there's Ewing's FLI1. Ewing's FLI1 does not equal Ewing's. We really need to take our molecular aberrations and put them into the context of the clinical, the morphology, and the immunophenotype. So let's take a step back and talk for just a minute about superficial Fettet's neurocystic tumor. To date, there's a couple case series and 2 case reports written about these tumors with a total of 10 to 12 cases. These have been shown over a very large age range from pediatric patients to adults. Most have been described in adolescents and young adults with a slight male predominance. Right now, there is very limited clinical follow-up, but perhaps suggests maybe more indolent than Ewing's. Of note, though, these have all been superficial location, and we know that superficial Ewings also have a more indolent or good prognosis. These tumors have consistent, strong expression of both S100 and SOX10. We know sometimes S100 may be present in conventional Ewings, but not SOX10. They can have NKX 2.2, but very variable membranous CD99. There's been a variety of Fettet genes fusions. Initially, it was just Ewing's FLI1 fusions described, but the most recent publication has also described some other variant Fettet fusions. So what do these tumors look like? So to date, these tumors have been described as being typically multinodular with trabecular, nested, and spindle cell populations, as seen here in 2 different cases described, and again showing that consistent expression of both S100 and SOX10 as shown here. And this is showing some patchy CD99 membranous expression. So this is something to keep in mind when we see superficial tumors that you may consider this tumor as well. To date, none of these tumors have been described in deep locations. So what about other round cell sarcomas with Ewing's non-ETS gene fusions? There have been a variety described. I'm not going to talk about all of them today, but we're going to focus on NFAT-C2 tumors and briefly on tumors with PAT-C1 gene fusions. So why are we talking about this? So I want to take a step back of when these first started being separated out from Ewing sarcoma. So this was one of the first papers back in 2018 that used methylation classifier as a way to highlight that maybe these round cell sarcomas that historically, I'm going to use the term that I really don't like, there was Ewing's and then Ewing's-like tumors really weren't the same thing. And so if we look at this methylation classifier and this Tisney plot, we can see Fettet's of conventional Ewings here. And we can see that these other round cell sarcomas form these distinct clusters. So here we've got NFAT-C2 tumors. Here we've got Chick sarcomas. Here we've got DSRCTs with Ewing's WT1 tumors form, at least by methylation, these distinct clusters. And this was back in 2018, before the last WHO. And then we started recognizing that not only by methylation, but by morphology, immunophenotype, et cetera, and clinical, that these really were distinct entities. And so what about these sarcomas with NFAT-C2 gene rearrangements? These clinically, morphologically, et cetera, really are distinct. So these tumors are more common in males than in females. They typically occur again in adolescents and young adults. And these more commonly than not are in bone, but can occur in soft tissue as well. By immunophenotype, these can show CD99. They sometimes can show NKX 2.2, but interestingly, they also may express a marker that we more commonly think about as a prostate cancer marker, NKX 3.1. They can show PAX7. They may show EMA and keratin. They may express a newer marker, aggrecan. And then by molecular, unlike Ewing sarcoma and other tumors with Ewing genes rearrangements, that not only do they show a Ewing's fusion and break apart by FISH, they often show Ewing's amplification, which is seen here in this by FISH. So this is actually the first case I ever saw of a Ewing's NFAT-C2 case, and I'll show you the morphology in a minute. But when we sent this for Ewing's FISH, not only did we see a gene rearrangement, but we also saw Ewing's amplification. Of note, NFAT-C2 fusions are also present in simple bone cysts and vascular malformations of bone, and we're not going to speak about those today because I don't have time. So what do these tumors look like? This is a case in soft tissue, and I know I just told you that these are more common in bone than in soft tissue, but this was the first case I ever saw of a Ewing's NFAT-C2 tumor that correlates to that FISH that I just showed you. This was a soft tissue calf mass in a young adult woman, as highlighted here on imaging, and then this is the morphology. So these tumors tend to have two morphologies that are very common. One is a myoepithelial-like morphology as seen here in this multinodular mass. And when we look at higher magnification, we can see this chordate or trabecular architecture, often in a kind of chondromyxoid stroma as seen here. The other more common morphology is just sheets of round cells. These can occur in isolation with either morphology or hybrid tumors. This one tends to have more of a myoepithelial tumor. This was initially diagnosed as a Ewing sarcoma because we didn't know about NFAT-C2 tumors at the time. And when I received this case in consultation, I was like, this doesn't look like any Ewing sarcoma I had ever seen. We sent it for FISH and then ultimately sequenced it. As you can see here, the CD99 is kind of patchy, mostly cytoplasmic, and then didn't express any other myoepithelial markers. Here's another case in a pediatric patient that showed an intra-abdominal mass. This also was Ewing's NFAT-C2, but shows somewhat of a myoepithelial pattern with some various kind of hyalinized stroma here and trabecular architecture, but then more sheet-like round cell pattern as well. Here's a bone-based lesion in a young adult. We're going to say 40 as a young adult man with an intramedullary radial mass. This tumor showed patchy CD99 and focal keratin, and again was a Ewing NFAT-C2 tumor. Here we see a more nested morphology with scattered osteoclastic-like giant cells. Focally, these tumors may express heterologous elements, including cartilage. So what about PAT-C1 rearranged sarcomas? To date, these have only showed Ewing's rearrangements with PAT-C1. These show an equal sex predilection over a very wide age range. To date, these have only been soft tissue based. By immunophenotype, these are polyphenotypic. In the bone and soft tissue world, these have been very controversial of how best to classify these tumors, given that they are polyphenotypic, including showing myogenic markers. Likely in the new WHO, these may be reclassified into an unclassified differentiation rather than round cell sarcomas because these have such a polyphenotype, including epithelial markers, including keratins, as I just mentioned, myogenic markers, including desmin, myogenin, MyoD1, neurogenic markers, including S100, SOX10, and others. These may show sometimes some CD34 and rare CD99. What do these tumors look like? These often are encapsulated and kind of multilobulated or at least separated by fibrous septae. One of the clues I like to use is that they often have these kind of macrofollicular or kind of this cystic spaces within the tumors as seen here on low magnification and then again on higher magnification. So there's kind of these follicles that form. And then the cells themselves, or the cytomorphology, may have either a round cell pattern, an epithelial pattern, or a spindle pattern. And this was a mass in a 10-year-old on the chest wall. The chest wall, or the thorax, is a very common location. Here's that polyimmunophenotypic pattern with desmin, kind of dot-like keratin, some patchy S100, and very seldom is there CD99. Here is a different mass, but again, a very similar morphology with that fibrous capsule with these follicular or cystic spaces, and then either round cell to spindled morphology. This particular tumor, again, showed MyoD1, desmin, and a mix of keratins, S100, SMA, in this case, were negative. So what about other undifferentiated round cell sarcomas without FET-ETS gene rearrangements? In particular, we're going to focus on the chick sarcomas and the sarcomas with B-core genetic alterations. So chick rearranged sarcomas, and I know it's controversial. Do we call them chick sarcomas? Do we call them CIC rearranged sarcomas? I prefer chick sarcomas. These have a slight male predominance. Again, these occur over a wide range of ages, but usually they're in young adults. However, about a quarter of them occur in pediatrics. Most commonly, these arise in soft tissue sites or in the viscera. They're rare in bone, but they can occur in bone. These are considered to be a very aggressive tumor with overall, they have a worse overall survival than Ewing sarcoma. However, unfortunately, these are typically still treated like Ewing sarcoma, or sometimes in the adult population they'll be treated as an undifferentiated sarcoma. So what do these look like? I think most importantly, if we look at this tumor, unlike the first slide that I showed you of Ewing sarcoma, they look different, right? I think we can agree that these look different than Ewing sarcoma for the most part, even though we can argue that they're still round cell sarcoma, particularly on the left-hand side of this image. Yes, it's round cell, but within the same tumor, they often are very heterogeneous. So on the right-hand side of the tumor, we can see that there's some myxoid change. There's more pleomorphism than what we typically see in Ewing sarcoma. This is all the photomicrographs that I'm sharing with you right now are all from the same tumor. So within the same tumor, we can see rhabdoid morphology. So these tumors, we can see these eccentric nuclei with pink cytoplasm, so eosinophilic cytoplasm, the rhabdoid morphology. Often there can be myxoid or chondromyxoid stroma. Within the same tumor, you may argue that these are more plump spindle cells. Here's another tumor. So this is a different tumor, again with rhabdoid morphology. This was a 14-year-old with a thigh mass. Another common feature of chick sarcomas is geographic necrosis. So geographic necrosis, more pleomorphism. Often we can see prominent nuclei as seen here in these tumor cells. So what about immunophenotype? IHC for chick sarcomas can be helpful. The fusions lead to upregulation of several ETS genes, including ETB1, 4, and 5. These tumors may be positive for CD99, but not the strong diffuse membranous staining we see in Ewing sarcoma. We may see staining with ERG. And then I think most helpful in chick sarcomas is either nuclear or cytoplasmic staining for WT1 if you have that. And then if you have available, we often see staining for DUX4. And we'll talk about why that is in just a minute, but DUX4 nuclear expression is seen in about 95% of these tumors. And that comes to the molecular. So in chick sarcomas, the most common fusion is chick to DUX4, which is seen in about 95% of cases. There can be less common fusion partners, including defoxo4, not M1, not M2. But again, the most common is to DUX4. So in those tumors that are DUX4 gene rearranged, that DUX4 IHC is very helpful. And personally, if I have DUX4 IHC nuclear expression, I'm done and I don't necessarily follow up with molecular. If I'm suspicious for a chick sarcoma and DUX4 is negative, then I'll go on to sequencing. Testing if needed, there's chick FISH that's available, and then obviously sequencing. Sequencing, you can sometimes have some false negatives, as these can be difficult to detect. What about sarcomas with B-core genetic alterations? There are B-core to CCN B3 is the most common fusion. Within the BCOR gene fusions, these are more common in males than in females. Most of these occur in patients less than 20. So those are going to be our pediatric patients. These occur most commonly in bone than in soft tissue. Commonly in the pelvis, lower extremities, and paraspinal regions are the most common. Of note, we can, within the same class of tumors, have fusions that aren't BCOR. I know that's confusing, but there's been a rare publication of KDM2B gene fusions that cluster by methylation with the BCOR sarcomas. We also have BCOR IDT, or internal tandem duplications, ITD, sarcomas. These are formerly known as primitive myxoid mesenchymal tumors of infancy, or PMMTIs. These have equal sex predilection. Unlike the BCOR fusion sarcomas, these more commonly occur in infants, so less likely are adolescent patients. These, unlike the BCOR fusions, are soft tissue based primarily. Again, just to make it confusing, a subset of these BCOR ITD sarcomas don't have BCOR ITDs, but rather these YHWAE NUT-M1 fusions. And of course, because we like to have things confusing in sarcoma, we also have BCOR ITDs and other tumors outside of this group of tumors, but they do have shared morphology, such as in clear cell sarcoma of the kidney and in high-grade ESS. So what do these look like? So here's an example of a BCOR fusion, CCNB3 sarcoma. The helpful morphologic features to me is looking for the vasculature. Often these tumors have multiple curvilinear vessels. These tumors can be round to spindled and often have abundant myxoid matrix in the background. These tumors often will have these kind of clustered rosettes scattered throughout, as I'm highlighting here. Here, all of, again, the photomicrographs I'm showing are for one single tumor. So you can have round cells to spindle cells. Here, again, these thin-walled curvilinear vessels, these clusters, and some areas can be more spindled, as seen here, with a more collagenized background. This is a different tumor, but I would argue have the same features. Actually, this was a case I had of this 12-year-old male with a chest wall mass. I froze this, and the surgeon asked me, is it Ewing's? Is it, quote, Askin's tumor? And I said, no, I think it's going to be a BCOR tumor. Don't do that on frozen, but I did because it had these classic BCOR morphology features. Can IHC help with BCOR? I think the IHC is much less helpful than in a chick sarcoma. There is some nonspecific staining for CD99. BCL6 is often positive. Cyclin D1, BCOR is positive, but it is not specific. In tumors that have CCNB3 gene rearrangements, they'll be positive, but that's only a subset of cases. So often in this case, you do need molecular. This is my second to last slide, so we're almost there. So when we're thinking about round cell sarcomas, we kind of went through the, big common round cell sarcomas. If it's none of those things that we just talked about, what are some other round cell considerations? So infantile fibrosarcoma can have a round cell variant. There is kind of a new kid on the block, which is KMT2A YAP1 round cell sarcoma. These have an SEF-like morphology. Of course, DSRCT. There are nut sarcomas and nut carcinomas that can have round cell morphology. These can overlap with Ewing sarcoma. And then extrarenal rhabdoid tumors. And I've listed here some helpful IHC to help you out. So in summary, round cell tumors have really expanded beyond Ewing's. The diagnosis really relies on the integration of the clinical information, the clinical demographics, bone, is it in bone, is it in soft tissue? Morphology really can be helpful, so can immunohistochemistry, and of course, the molecular. But the molecular needs to be interpreted in the context of the clinical, the morphology, and the immunohistochemistry. And with that, I thank you, and I think now it's time to open up for questions.
Wow. Thank you, Jessica. This was really a tour de force. Well, thank you both of our speakers. We'll give the microphone to Arnaud to respond a couple of the questions that are present, and then I have a couple of questions for Jessica. Arnaud,
Yes.
Isabel, you want to address the questions, or you want to read them? They are in the chat.
I read the question.
Arnaud can read the questions.
Yes. So the first question was Spitz melanoma. Would I be able to establish a diagnosis without genetic studies? I think for children we have to do the maximum because of the importance of really this impact on the child. So right now I'm doing the maximum for these cases to ascertain that it's a child. It's really a melanoma in this child. So what I'm doing is I'm doing whole exome RNA sequencing, and I'm doing WES, which is CGH plus NGS. So that's really to have all the elements to be sure that I am really putting this tag over this child's head and his parents. So I think it's very important. We have now the ability to do this. These cases are rare, and we have to do the maximum in terms of research for this population. And because there is a risk of overtreatment and overdiagnosis, which is very impactful for the child. The second question was about molecular, how to do molecular. For a Spitz nevus, if it's the common Spitz nevus on the knee in a child, you don't need to do any molecular testing. You can answer Spitz nevus. If you think it's going to be something atypical, meaning you see a clone that is different, then P16 will be the first immuno to do. And otherwise, then you can maybe go on to CDKN2A, FISH, if it's P16 is lost, or MTAP also is a new antibody that can be useful in this setting. That's, yeah, for if you want to do the fusions, that's when you have hesitation between SSM and a Spitz. So if you want to rule out SSM, you're going to do BRAF immuno, BRAF B600E. If it's positive, it's not going to be a Spitz. That rules out a Spitz. So that's when you do, if you find the fusion, that rules out SSM. So that's how you use most usefully, this is always done in an algorithm. For all the questions regarding what we do in terms of methylation, I do not do methylation. I do whole exome RNA sequencing. And in that setting, we're doing some UMAP-like analysis, like I'm showing you on this slide. So basically, it's the same as methyloma, but with known of genetics. So that's what we're doing. We have currently 10,000 tumors in our cluster, including more than 1,000 melanocytic tumors. So we're trying. So this allows us to do volcano plots to look at gene expression profiling, and of course, we're now trying to overlap cases where we can do both methyloma and this type of analysis to move forward. And then there were some questions. So I am working with the University of Utrecht with Willeke Blocks on AI to identify molecular anomalies. I have a collection of more than 500 cases of genetic annotated Spitz tumors. And then there were some very specific questions about MYO5A. So this is like the problem when you outsource genetic data and how to interpret genetic data without the histology. So this is what we're trying to avoid. So it's always complex because not every anomaly has the same weight. Do gains of some areas like 8q will have a more impact than a loss on some areas. So this is a matter of doing molecular tumor boards, which we do each week, to discuss how every anomaly is going to impact. And it's very hard to say, if we have more than this amount of anomaly, then it's not a typical tumor, it has to become a melanoma. So it's taking account the clinical data, the morphology, immuno, and then everything. So it's a really complex task that we have to move forward, but it's not like one rule for all algorithm to come to a diagnosis. I think I've answered most of the.
Thank you, Arnaud. Thank you very much. I have a question for Jessica. A couple of things. One is the spectrum of morphologies in Ewing sarcoma along many years have produced a number of theories about cell of origin. One of them that intrigued me for many years was the possibility of being a neural crest-derived tumor. And when you showed this case from Ari in UCSF that had a neuroblastic differentiation, that came back to my mind. What is the current status of these pathogenesis, cell of origin, etc. theories, Jessica?
I don't know if I mean, it's a great question. I don't know if we know, right? The naming and the nomenclature of Ewing's has gone through several iterations, right? We used to separate Ewing's and peanut, right? And then peanut went away, and it kind of phased out, right? It existed in CNS still, and then we deleted it. I think peanut only exists now in the GI tract, and we've just lumped those together. So we know that Ewing's can have rosettes. We know that Ewing's going to have neuropil, but we don't separate that out as a subtype anymore. And so, is there a difference depending on, now as we're doing methylation, we know methylation can change depending on the cell that it arises from. So extraskeletal Ewing's versus soft tissue Ewing's, are we going to see some differences? I've been doing some work in a subset of Ewing's that are Ewing's to ETV1 that have Desmond expression and are infants and are all soft tissue based, and those seem to cluster separate from classic Ewing. So I think we're going to continue to learn more, Miguel. I don't think we have all the answers yet. And so is it because of the cell of origin that fusion is occurring in that makes it slightly different? Do we know? So I think we still have a lot to discover as we're continuing to do some of what Arnaud is doing. We're doing methylation, we're doing RNA-seq. We're going to continue to learn more.
Yeah, the question about cell of origin has lost a lot of relevance, and probably the real question is the cell of destiny in terms of differentiation, right? Because cells can move from one origin to another. But this brings back to my mind the issue of the neural crest, because I am a neurocrystomaniac, as you may know, and all phenotypes can derive from a neural crest cell because that's a totipotential cell, and that connects with Arnaud's presentation and the multiple phenotypes of all these nevus, spitzoid, melanocytomas, etc. So wonderful talks. Thank you both very much. Our next webinars will be on the 25th and 26th of this month. We have 4 outstanding speakers coming, and I will look forward to seeing many of you joining those sessions. Isabel, would you like to close the session, please?
Thank you. Yes, thank you, Jessica, Arnaud, Miguel, for taking the time to be here. And thank you, obviously, to all the attendees that have joined our seminar today. And I'll see you next week.
We forgot to mention that this has been an important contribution from Dr. Martha Cohen, who has been pushing for these webinars and supporting all of us. Thank you to all of us. And the staff, Kristen and all. Thank you. Goodbye.
Bye.